Let's turn to ALK-positive patients. And we've gotten more and more data and some more options. At this point, would you say that alectinib is the clear first-line standard of care for a newly diagnosed patient?
I would say yes. I think for the same arguments or similar arguments that we made for osimertinib for the EGFR mutant lung cancer patients, I think, the survival advantage plus the CNS activity that we see with alectinib is far superior to at least crizotinib. I mean, that was the trial comparison, and that's certainly, in terms of tolerability, it's become my first go-to choice.
I agree. I think alectinib has been my standard of care. I guess the only question is, should brigatinib be also considered as a potential frontliner at this point?
At this point, we have ceritinib has an approval.
Yeah.
I don't think we spend a lot of time agonizing over its place, but brigatinib has positive data from the ALTA-1L trial against crizotinib, but it's early data, and we have a comparator, or we have an alternative in alectinib that is a pretty well-tolerated and very efficacious agent. So where does brigatinib or even ceritinib bubble up here?
That's a good question. I mean, I don't know exactly. Ceritinib, I would say, probably further down the line, if for somebody who's progressing. I think at this point, I'm still starting with alectinib as my standard of care or as my first choice. And I think the data that I've seen with brigatinib is very thought-provoking. But again, we don't have had that comparison of brigatinib versus alectinib in this patient population, and we're unlikely to get anything like that. So I think then you look at and see what the activity of the other agents are post-alectinib and try to select the drug that best suits that if you just use clinical parameters. This concept of doing mutational analysis after each progression on one of these TKIs has been percolating. It's only possible in a few centers, takes time and all of that. But I think it's an interesting approach because, again, talk about personalizing the delivery of care. You start with one drug, you do a biopsy, you figure out what the mutation in that tumor is, and you offer a corresponding drug that can hit that mutation. I think that's the sort of the holy grail of what we want to do in oncology. But it is a little bit cumbersome, and I think we're going to have a NCI-sponsored study trying to look at that kind of an approach, which I think is very welcome. But for now, I don't think I'm going to be switching out of alectinib to anything else.
So just pulling it back to first-line diagnosis, we have alectinib as approval, we have ceritinib, and we have data that looks strong for brigatinib, but how do you weigh the choices?
I think alectinib is still my favored approach just because I have more experience using it. I think, the side effect profile is, I can't compare alectinib and brigatinib head-to-head. There have been slightly higher reports of pneumonitis with brigatinib, but I do think that, given the history of using alectinib over the past couple of years at least, we've become comfortable with it. The data supports it, so I'm more favored to use that frontline, even though the brigatinib data compared to crizotinib looks pretty good.
Yeah, I think brigatinib looks quite strong, but that's against crizotinib, which is definitely a weaker competitor than alectinib by a long shot. It has very good CNS activity, but we know that the second-gen agents, including alectinib, broadly do have that. And the pneumonitis risk, though it's 3 or 4%, is more of a consideration than alectinib would be. I think that maybe with much longer follow-up, if brigatinib looks like it has efficacy that lasts far longer, well, that could possibly differentiate from alectinib, but you just can't know that from the initial analysis where, yes, it looks better at a year, but that doesn't even speak to the issue of our current standard of care of alectinib. We've just moved on, I would say.